Thank you very much all for being here with us. Thank you for this important session wherein the topic is COVID-19 in pregnancy, and the presenter would be Professor Carlos Simón himself. So I've been told that Dr. Carlos is already there with us. Welcome to this webinar, Dr. Carlos, and thank you very much for sparing your time.
It's my pleasure. Thank you. Good morning to all of the colleagues. Good morning from Boston, and thank you to my colleagues from Igenomix Asia Pacific that invite me to really give you this presentation. I don't know if you can see me. Yeah, I think that you can see me now. It is my pleasure to be here with all of you. And as Bikram indicates, the topic of the presentation is to sum up what is known now after these 6 months of pandemic about the COVID-19 and what is related to our field of expertise, which is human pregnancy and assisted reproductive technologies. So the first thing that I would like to do, I don't know if you can see my camera. The first thing that I would like to do is just disclose my conflict of interest, that I am the founder and the head of the scientific advisory board of Igenomix, and together with other duties that I have done in the last 5 years, that as you can see here, as editorial editors of Fertility and Sterility and American Journal, and also external scientific advisor of international scientific societies, of governmental agencies, societies as ESRE, as ISRM, and also private companies as Ferring or MSD. And what I would like is just to go on the presentation and letting you know that the learning objectives of this presentation today is going to be first to review what is the impact of this COVID-19 disease and SARS-CoV-2 virus in your area in Asia Pacific, and to understand what is known today. Second, what is known in reproductive medicine? What is the message that we can have, that we can pass to our patients? Whether this would be important, and then at what extent the virus can be found in the semen, can be found in as responsible of miscarriage, what is happening with the vertical transmission. All of these, I think, hot questions that we need to know in order to answer to our question, to our patients. And finally, I would like to address how to restart our clinics, depending on the moment on the pandemic that you are in. And I will just explain you what is the European experience and the American experience for you to have this as a backup for you to know how to do it. So the first thing that I would like to do is to review with you where are we after these 6 months of the pandemic. As you know, COVID-19 is this disease caused by SARS-CoV-2 virus that it was declared as the pandemic as 11th of March. Nowadays, worldwide, more than 10 million cases with more than 500,000 disease. And you can see just largely what happens in China, that it was where everything started. Then the epicenter moved to Europe, and nowadays is in the Americas. But these are the numbers that you can have. More than 2.5 million cases. Europe and United States, China stay controlled, even if this was the primary place where it started. This is just the situation in the worldwide. Now, what happens in Asia Pacific? Let's start by UEA. As you can see there, the disease is behaving in waves. So it was an increase by June, but then it recovers, and now it's going back another wave of daily deaths and daily new cases. So it is something that even if there is only 48,000 cases, 315 officially deceased, the pandemic is behaving like is going down, but still there are waves that require attention. In India, unfortunately, the situation is quite different. You are just getting up in the pandemic and you are getting to the peak. So new cases, they are increasing every day, and you are going to have an increase of deaths very soon. So you are at the moment that you did not see the peak yet. You are about to get it, but so it is still time for you to really concentrate in the lockdown and not do anything else by taking care of your life. So as you can see, there are different moments in different places. China is just the opposite. China, everything started, as you can see what happens in February. However, nowadays, there is almost not report except outbreaks that they are happening everywhere. So the life there, I think that came back to normal, except in specific places where has been outbreak detected, and they have been taking measures about that. And finally, Japan has been quite mild affected. So this is about the way that every country just confront the pandemic. But Japan, in general terms, only 18,500 cases with 900 deaths. You can see the evolution, and those cases were just getting down. So it is in a better situation nowadays. So this is the situation that you have this Asia Pacific area in terms of the time of the pandemic for many different reasons, of course, that I cannot go into all of them, but this is the general picture. Now, where are we? I mean, this coronavirus is the third pandemic that happens in the 21st century. As you know, this is a virus that propagates by the air, and the illness can cause from just common flu to total fatal outcome because of respiratory distress. We know that this is the third pandemic that happens this century, produced by the same type of virus, which is coronavirus, and the name, I will explain you later why the name is coming from. But these recurrent spillovers suggest that future zoonotic transmission is going to occur. So we have to be ready, not for what has been happening, but we have to be alert, because all the data indicates that another zoonotic transmission coming from animals to humans may be able to occur because of this situation. Now, what is this virus? You can see by the electron microscopy, and this is why they call them coronavirus. And the reason is because these spikes that they have, and this is the way that the virus gets attached to the human cells. This is an RNA, single-stranded RNA virus. It's very small. The size is just like 3 mitochondria, but they have those spikes that they are able to attach to the human cells through the gate. The gate is just this ACE2, which is angiotensin converting enzyme 2, and this is a part of the renin-angiotensin system. And the only reason is because their morphological affinity, and that's why it gets bind to this and enter the cells and produce the effect that the virus is able to produce. This ACE2, as mentioned, is just part of the renin-angiotensin system, which is taking care of our blood pressure. One of them that is able to cut angiotensin 2 in angiotensin 1 to 7, and by doing this, it just produces the effect on the MAS receptor. So this is a system, but the only reason to bring that up is because ACE2 is the gate entry for the virus to produce the effect. This is just a diagram of, this is like a radiography, an X-ray of this RNA virus. As you see, it has only just 3,000 RNA letters that codifies two types of proteins. These structural proteins that forms the spike and forms the system that I'm going to explain you, but also non-structural proteins. All of these 30,000 letters just produce 29 different proteins, all working together with three main objectives. One, to replicate the virus. Second, to suppress the body's immune response. And finally, to release the virus copies to our system and propagate the infection. This virus is very contagious, and fortunately, mortality rate is low. And that's the only reason why I think we can just be happy about that, because with this amount of infectious, if the mortality was higher, we will be in a very important trouble, even more than we are now with this situation. So this is the X-ray of the virus, and as mentioned, it has been identified this protein that is the NSP12 and 7 and 8, that they are basically copy machines of the virus, that they are able just to replicate and to produce more and more virus. There's the NSP1 is just the cellular saboteur, which basically suppress the body's immune response, and that's why this virus used to escape from the immune response of the host. And the problems are even bigger if basically if the host is immunosuppressed, or if we are just into the high-risk population as elderly or patients with respiratory chronic problems. And also there is a NSP4 and NSP6 that they are just like the factories to produce more and more, just the way that they release these viral particles from the cells. They are basically managed by these two master proteins. And because of that, once it's produced, it gets immediately released. And that's why this virus can go to the air and be able to infect another people, or just go to the surfaces where the virus can survive for about 1 or 2 days. Now, this is the introduction about what is the situation of the disease. And I would like to discuss with you what is now known about the COVID-19 in reproductive medicine. So the first question that we have is to find out whether it's in our system, whether it's in the reproductive tract. And about the male, the first question to ask was, this virus can be found in the semen of persons, of males, that they have been infected with COVID-19. Well, as you can see, all the papers and all the publications that I'm going to show you, they have been released in the last 1 or 2 months. And as the time goes by, you can see that the numbers have been changed and the message has been completely changed also. So the fact that you see that they are not consistent means that the information has been updated. So regarding this question, is the virus present in the semen? The first paper published in Fertility and Sterility by this Chinese group, which is where everything started when initially the information came, indicates that is not the case. So it is very unlikely that SARS-CoV-2 enters in any of the cells and Leydig cells, and there was no information about that, no evidence of SARS-CoV-2, and then no sexual transmission of that. This was first paper 1 month ago. Another paper came in Biology of Reproduction, studying 13 samples, 12 semen samples and 1 testicular samples, and the results were the same. So there were no absence of coronavirus in semen. However, just very recently, it came this publication from JAMA, which is the Journal of the American Medical Association, that for the first time they find out that this is the case. So they analyzed a total of 38 patients in which 23 participants achieved clinical recovery, and 15 they were at acute stage of infection. All of them, they have the virus in the system, but some of them they were acute and some of them they were recovery. But the point was that out of all of these 38, 6 patients present positive results for the virus in semen samples. 2 of them, they were recovered, among brackets, and 4 of them, they were in the acute stage of the disease. No significant difference were found in terms of age, urogenital disease, or days from symptoms, but this raised the doubt about the potential sexual transmission of the virus from infected males. So this is the first time that that came this, and so we have to consider this as a situation when the time comes to reassure that the semen obtained is not infected with the virus itself, because it raises also the possibility of the sexual transmission. What happens? The other question is, it is possible that the virus will just cross the endometrium, will go to the endometrium, infect the endometrium, and then can just cross to the fetus and produce either miscarriage or vertical transmission. All of our work in the endometrium indicates that it is very unlikely that the virus will infect the human endometrium, and we have just analyzed what is the ACE2 and all the internal pathways to enter into the endometrium, and they were very scarce. So it is very unlikely. So infection of the uterus, it is quite unlikely. However, I have to show you this data that came also very recently from the Journal of the American Medical Association, in which they documented the existence of a second trimester miscarriage in a pregnant woman that she was carrying this SARS-CoV-2 infection. So you can see the details in the screen, but basically the patient tests positive for SARS-CoV-2 in the nasopharyngeal swab. Then she starts with uterine contractions. She has this miscarriage. She has this stillborn. And when they analyze the placenta, they found that they give positive for SARS-CoV-2. And again, the samples collected, this was at day 2, and day 4, the patient is still positive for the nasopharyngeal swab. So we don't know whether this is the cause of or the consequence, but the point here is that in a patient infected with COVID-2, miscarriage occurred, and it was detected in the placenta. So this transmission happens. It came from the patients to the placenta because it was already detected there. Whether this was the cause or the consequence of the miscarriage, this we cannot know because this is just a case report. The other question is, what about vertical transmission? I mean, it is possible that the baby could be infected from the mother during delivery. So the first studies answering this question came from China, and this is the summary of 7 studies. You can have references here, in which they analyzed 44 babies already born, in which 15 were preterm and 29 were term. There was no, I mean, the reason for preterm is more anxiety than any other thing. But in those cases, no newborn was found infected, after the delivery from patients that they have the infection. However, again, new publication came from this JAMA Pediatric, in this case, in which now they study these 33 neonates. This is just a single study in which they find out that, in 9% of cases, 3 out of these 33, they find out that the neonates were positive after the mother infected with COVID-19 delivered. The 3 babies, they are okay, and only one require a real strong treatment, because also he was a premature baby. But this was just to show that the fact that this virus, the vertical transmission, is a fact in 9% of cases. So the lesson from that is just not rush for the delivery, rather to have that the patient will pass the infection, and not to treat with a specific antivirus, because it was also creating some problems, as we learned in the first pandemic. But this is just to illustrate that this is also a possibility. And in fact, nowadays, there is an AJOC paper just came last week in Iran, in which not only that, but the fact that the patients, that the pregnant patient, they got infected in the 3rd trimester, it's also produced mortality and high morbidity. So patients without previous respiratory background, they got fatal on that. So this is something to consider, that COVID-19 could complicate pregnancies, and also vertical transmission has been reported. Okay, so this is the available information, just to keep in mind all of this. Now, what about IVF? What about in our own field, in reproductive medicine? What has been done worldwide in terms of restarting the reproductive clinics? Well, as you know, first is life. Life is first, of course. And once you detect the pandemic, the first thing to do is to go for lockdown. And this has been what the complete planet has experienced. Empty streets. And depending on the moment of the pandemic, this is the right thing to do. For instance, India nowadays is still in this phase, so it will be highly advised to do that. But as you see, other parts of Asia Pacific, they are just getting out of this. What to do next? Well, we need to have the knowledge. We need to identify who are the patients that they are infected, in order to isolate them. Lockdown isolates everybody. A specific knowledge about the testing of the patients will allow us to identify those possible carriers of the infection and possible responsible of outbreaks. Of course, the patients at risk, that are, as mentioned, elderly, immunosuppressed, and patients with respiratory chronic diseases, should be tested first and should be isolated. But the rest of the population, which is the majority, should be also considered for that. In fact, in this slide, you can see how different countries, some of them in your area, has navigated the pandemic by the fact, not only by the number of tests or the percentage of tests that they have done, but also when they start to test the population. As you can see, South Korea, that they navigate very well this pandemic, start to do the test very, very soon, even if they just did 11% of tests per 1,000 people. And some countries, as Italy and also Spain, even if we did many tests, the results will start very late to do that. Germany is another example that they did very well, because they start very soon analyzing the population as many as they could, and also they keep analyzing this. Recently, some outbreak has occurred in Germany also in a specific factories, meat factories, and outbreaks occurs everywhere. Singapore is another good example, and also Sweden. So this is about, and here you can see Japan and Taiwan that are the most, you can see how well they have been doing, but they have been testing the population from the very beginning. So this is something to keep in mind, that testing, as WHO indicates, is crucial. And as soon as it was detected, as soon as the governments, they were aware of that and they start, the situation in the countries, they were better navigated. Now, what is the identification methods that we have? Well, as you know, we can either detect the virus by detecting the nucleic acid of the virus, the RNA, or we can detect what is the body reaction to that. So we can detect the antibodies that we produced upon the infection within this virus. So this is the typical diagram in which the virus that can be detected when the virus is present, and then this virus elicits the production first of IgM, IgM or IgA in this case, because it's the respiratory tract, indicating active infection, or IgG that indicates past infection and immunity among brackets. But this is what is interesting about this pandemic, and the reason why it has been so contagious. So as you can see here, the type of the population is very, the symptoms could be either mild, moderate in 55, or no symptoms. So you have 85 of the population that you will almost not notice that they are infected. Whereas in 15% of the population, they will have either severe symptoms or just critical symptoms that it will be mandatory to use artificial ventilation in order to keep the patients alive. And this has been the main bottleneck for health systems, and the mortality is related to the amount of ICU units that you have per capita. So, but the point that I want to make, and of course mortality is related of whether this is a patient with critical symptoms or this is asymptomatic. Almost no mortality here, and here you can see that at the end of the day becomes like a flu. It's about 3–4% of mortality altogether. But the point that I want to make, that in any case, even in those cases with the critical symptoms, there is a period of about 5 days in that there is no symptoms whatsoever. And within this period, the patient is contagious. So the contagious period extends from this with no symptoms to up to the 14th day in the case that there is no symptoms, or up to the 21st day in case of mild to moderate, and of course longer in those with severe symptoms. But in any case, there is a window here where the virus spread out because there is no symptoms, and that's the main reason of this pandemic here. Now, how can it be detected? It can be detected basically by techniques that allows to identify the RNA, which are RT-PCR or next generation sequencing, or those that allows to identify the antibodies, which is ELISA, in which we can quantify this response, or just rapid tests that they only have a threshold to give positive or negative, or rapid tests for antigen detection that I can tell you that those rapid tests has been very unsuccessful and has been a lot of frauds, and really they are not being used nowadays. Typically, we use RT-PCR, which is the more safe and secure, about 99.4% detection of RNA. It means the presence of virus contagious, and also NGS is the same. And by ELISA, we can quantify this. So we used to have this both together, in which you can see whether the virus is there, is contagious, and whether you have IgG, which means that you have been already the contact with the virus previously, and you are not contagious anymore, but rather you are immune. I will explain you this concept later. So I think that this is the system, and I want to show you the experience in Spain from the first 1,000. I mean, we analyzed the first 1,500 cases after the pandemic. So we did this study in the very first cases that we analyzed for COVID there, in which what you can see, Spain has been suffering the pandemic with a very high impact. And in Spain, we had about this number of confirmed cases. Nowadays, we believe that there is about 40,000 deceased. And we analyzed these 1,500 asymptomatic adults after the lockdown, when they were about to go back to work in the three main cities, Madrid, Barcelona, and Valencia. So, and we did the RT-PCR and serology test. The message here is that, as you can see in this diagram, we find out that in 3.7% of cases, RT-PCR was positive. So even after the lockdown for 2 months, we have about 4% of people that they carry the virus and they can start again outbreaks. And only 2.8% of patients, they were positive. I don't know if you can see here. Okay, so again, 3.7, they were contagious, and we only have 4.3% in which they have immunity. This is what we call herd immunity, in which the serology was positive, IgG was positive, and this was negative. However, there is a 2.8% of cases that even the serology was positive, the virus was still present. So it means virus persistent or reinfection. And you have to keep this in mind. The presence that IgG is there, it doesn't guarantee that this patient is not going to have the virus also. It's very unlikely, but it's there, and you know, in medicine, it happened. So these are the numbers that you have to expect after the lockdown when the cases goes down. So you still have this 4% of the presence of virus in people, and 4.3, I mean, let's say 5% of immune, and but it could just come down in 2.8% even in the presence of IgG. And this is the reason why outbreaks, they are occurring now. So what happens in assisted reproduction specifically? So the first thing that I want to let you know is a message of calm, that the fact that the delay in pregnancy, the impact of IVF delay is not going to be important. And this paper just came in Human Reproduction just 1 week ago from Cornell, in which basically this is a retrospective study that they try to see what is the impact of delay up to 180 days. There is no effect on the delay of the treatment in terms of the clinical results. We are aware that our patients are anxious. We are aware that the health is first. So I think this brings comfort in terms of understanding that in the moment of the pandemic, where is still the peak is not there, we should wait, and the fact that we wait is not affecting live birth, and this is a message that you can bring to your patients, and suggesting them to wait a little longer because life is first. So this is the message, that even those with diminished ovarian reserve and those with poor response, it will not affect, and this is the numbers, to wait this time, because you should do it for healthy and for safety reason. And the second thing is what to do when the time comes. So this is the concept of COVID-free clinics. Different clinics in different parts of the world, they are using different measures when they will come back. This can be from the famous triage, which is basically to ask about whether there is you have any problem. Do you have cough? Do you have fever? Which is quite obvious. Or just to take the temperature as you come to the clinic, or you just do the immunoglobulins, or rather you go for the whole package, which is basically to do the PCR for COVID-19 plus you do the immunoglobulin test. This is what we call the biological passport, to really have the whole idea of what is the situation of the patient, whether the patient is contagious, and whether the patient is immune. Depending on what is the status in which the patient are, you will be able to detect only PCR positive, the presence of IgGs or IgA or IgM, but you will only have the whole picture by having both of them. And this is just an example of a study that we are doing here in the United States in 2 different areas with different impact of the disease, in which basically we are testing what is the relevance of this biological passport. In one clinic in Utah, we are analyzing 200 patients here, 200 patients and workers. The idea is to do this in every patient working in your clinic, either is a worker or just a patient entering, offering the possibility to have this test and to know the patient that is getting into a COVID-free environment. So again, we are testing this in a clinic in Utah where there is very low prevalence, and the other in Massachusetts where there is a high prevalence of COVID-19. And we are trying to do this in saliva, which is the way to do it for the patient, so the patient can have this test done prior to come to the clinic, and then we will know at what extent it will be worth it to go through this exercise to prevent outbreaks and to prevent unwanted infection during treatment. By doing this, what we have seen in other clinics, that basically, if you know that you are in a free environment, the patient can repeat that at the moment of the offsite pickup, and with this, you will be covered. I mean, in 2 weeks' time, it is the time to repeat that. But this experience should be, once we have it, we will just publish for our colleagues to know what is the situation and at what extent can add the peace of mind for both patients and doctors from this strategy. So this is what we are doing in order to have the concept of COVID-free clinics, from the information to the nasopharyngeal smear to the blood draw, and then to have the results in 24 hours. So this gives us in a situation that is what we are dealing with worldwide. If we have PCR negative and antibody positive, namely IgG, means that this patient is, among brackets, immune. This person has suffered already the virus and has IgG. So it means that that it could work. Of course, she has to take, or he has to take the measurements, but it will be less affected than any other person. If when the test is done, the PCR is negative and antibody is negative, means that this person is naive for the virus. So this person has to know that the risk is there, and that's why you have to use all the measurements of social distancing that we know, the use of masks. I mean, this is for everybody nowadays, of course, social distancing and masks. But if you know where you, then you can know whether you can be infected or not. And finally, the most important population is the infected one, in which PCR is positive, regardless of the status of the antibodies. If this person is positive, should be invited to really go for his personal quarantine, and then to isolate the people that has been in contact with them in order to prevent outbreaks. So this is the concept when the time comes. which means at the time of the end of the lockdown and when the restart of clinics occur in those countries that they are in a specific moment. Some others, they are already on that and they are doing this. And so these are the different ways that in different parts of the world we are trying to go to the new normal, among brackets, situation. So just to end up, what I would like is to give the conclusions, which basically the take-home message that I want to give from this presentation is that to effectively combat the transmission of the SARS-CoV-2, we need population scale testing. Testing is what we should do. In addition to the emergency lockdown measurements, testing is crucial. And we should do PCR combined with antibodies in order to know the status of our workers and our patients, to classify them into naive, infected, or immune in order to act in a diligent and medical way. And to resume IVF treatments should be considered where are you in the world, what is the pandemic situation in your country, and you have to try to do it creating a safe environment, treating your clinic as your home, of course, and this will require testing measures in order to have COVID-19 free clinics because of the effects that we already indicated during this presentation of how the virus will interact with the human. And with this message, what I would like just is to acknowledge that this is the work of a huge team, that they have been helping me to prepare this presentation, in which is Inmaculada Moreno, Felipe Vilella, and Xavi Santamaria, and Jaime Herrero, my secretary, and of course, all the colleagues from Igenomix worldwide, specifically now in the Asia Pacific area, that we are trying just to help you to navigate in this pandemic and then to go back to your work for the best of our patients. Thank you very much for your attention, and I will be happy to entertain any questions that you might have.
Thank you very much, Dr. Carlos. It was a wonderful presentation and an enlightening one. I'm sure the audience must have enjoyed it. Thank you once again. We do have a list of questions here. Are you able to hear me, Dr. Carlos?
Yes, perfect.
Yeah, great. So I have a list of questions here. The first question reads like, could genetics, I think this question means, could a genetic makeup play a role from person to person so far as the severity of COVID-19 is concerned?
Can you repeat the question exactly? What do you mean by that?
The severity of COVID-19 symptoms, would the genetic makeup be responsible? Does it vary from person to person as far as the genetic makeup of the person is concerned? Is it genetically connected?
Yes, this is a very good question, and many things has been done about that. Yeah, one thing is the strain of the virus. We know that the virus mutates every month or so, and that's why it gets this spread out. But also it's about the host. And there are genetic difference in the host in the way that they are suffering this infection. There is an obvious difference, which is male and females. The virus affects more and impacts more males than females, for instance. The age is also very important, and we know that more than 65 is just a risk factor by itself. But there is also a genetic footprint that is being unraveled now that accounts for the severity of the infection even in young people. And this is what is calling virogenomics, which is being introduced now in some tests. Here in the United States, I have seen some tests that they are just testing not only the existence of the virus, the RNA of the virus, but also a number of genes that could be relevant to understand why in some young people the virus is so aggressive and why it is not. So yes, the answer is indeed there is a genetic, I don't know footprint yet, but there is a genetic impact, genetic predisposition for the severity of this infection.
Thank you very much, Dr. Carlos. I have another question in hand. It asks, what about vaccination? If patient is awaiting for IVF, do you recommend for vaccination? And if the vaccination is given, how long to wait post-vaccination? Though the vaccine is not available as of now, but then this is the question.
Yeah, well, first, if you refer vaccination for COVID-19 is not available yet. So at the time that this is available, these questions may be answered according to what type of vaccine is that. But you know, as the things are going, we are not going to have a vaccine until next year, which is the time that it takes for the clinical trials. And there is a nice Nature issue of what are all the vaccines available worldwide and how they are trying to develop. And you can see that there are different type of vaccines according whether they attenuate the virus in one way or the other, or whether they use antigens from this virus. So depending on the type of a strategy that is being used for the final vaccine to be released, then we can think about what could be the paucity of the vaccine to be administered. But nowadays, unfortunately, I think that we cannot forecast that the vaccine will come in very short time because of the clinical trial. This is what they take in order to have the proper results. And don't be flashed by magical treatments, magical or natural propositions for that. It has been also a publication in Nature showing that those type of an unknown approach, just purely stochastics, they produce more harm than because people they trust in things which are completely out of the blue, and there is no reason for that. So be aware that there is no magic solutions, because the magic world is not medicine, is not science.
Thanks, Dr. Carlos. Since time permits us, for the better understanding of the audience, I would like to stay on this question of vaccination. Since the vaccine is not available, in your personal opinion, how do you see the couples who are looking for an IVF treatment, or the clinics who are all prepared to, entertain couples for IVF treatment? How should they go ahead in the present circumstances with the present tools we have in hand?
Well, the only way at this moment is prevention, is safety measurements. First, it will depend very much in which country on the world you are. What is the moment of the pandemic? And in Europe, they are now getting back to normal. They are recovering their normal life. Clinics start to resume, and also in United States. So the most important thing is to know that you are in a free, COVID-free environment. When you go to your clinic, I mean, this is what we did in Igenomix. We just test everybody that is going to work in the first day. And this is what many companies are doing worldwide. Orchestras, they are opening the season for opera, for instance. So the first thing is that we know that every musician is free of COVID-19. It will be the same. So it's to know that first the clinic is free of the disease, and then the patient, when they come to the clinic, they do the test the day before, so they know that they are not do not carry the virus, neither the place that they are going will be carried. And then to have the social distancing, to have the mask, starting the treatment, and then to be able to check that in 2 weeks' time about the oocyte pickup. And with that, this is the best that you can do. And some people, some clinics, they do it. Others, they just don't do it. Others, they just do the immunoglobulins. Others, they don't do even immunoglobulins. As we have, I think that the first, when you go back, you want to be sure. And once you gain this consistency, then you can decide according where you are in the world. But keep in mind that an outbreak in your clinic could be a disaster, not only for safety issues, but you may have to close the clinic again, or the patient will be scared to go to a clinic where an outbreak has been produced. So you have to balance all of this. I think this is the best suggestion that I can tell you.
Thank you very much, Dr. Carlos. One last question. How much do you think the virus affects the sperm? If already the sperm is infected, will it affect the fertilization?
Well, we do not know how it will affect fertilization, but certainly if it can infect the patient, it will be a disaster. So I don't know, has not been proven at what extent fertilization is affected with an infected semen. But certainly you are introducing what you try to avoid, which is the virus into the ecosystem of the patient and the IVF clinic. So by itself, I think this is what you have to keep in mind.
Okay. Please permit me for one more question. Please. What is the incidence or presence of COVID virus in semen samples of asymptomatic and serologically negative individual?
You mean serologically? Serology is not trustable. When we say infectious, means the presence of the virus itself, RNA. It means PCR positive. So according to this paper that I show you, and I can repeat, I think that it was about 16%. So this is the paper here. So you have these 6 patients that they were positive, 6 out of these 38, and they were 2 of them, they were recovered, so they have no symptoms whatsoever, and PCR was positive, and 4, they were in the acute part, in the acute moment of the infection.
Thank you, Dr. Carlos, for being so kind, for taking up the questions and giving the appropriate replies within your realm. Thanks again. And before we sign off, I would like to thank the audience for being such a wonderful audience, such a patient audience. It was indeed a pleasure. But my message to the audience goes like, don't forget to tune in for the next episode of this Igenomix webinar series for Middle East and Asia Pacific. It's almost a fortnight away. You will be notified in advance. Thank you very much again, and back to Dr. Carlos. Dr. Carlos, do you have any closing remarks?
Just be safe. Just be thoughtful on this situation and think in your patients and your clinic as if it was your home. I think that this is the message that everybody should take from that.
Thank you very much, Dr. Carlos.
Thank you.